Hello, my name is Duncan Silcock. Today I'm going to be doing a synopsis and critical analysis of the abnormal structure of fear circuitry in pediatric post-traumatic stress disorder. First, a little bit on what post-traumatic stress disorder is, or PTSD. It's people who have experienced or witnessed trauma, have intense or disturbing thoughts or feelings that last a very long time after the traumatic event has ended. It can include some symptoms such as flashbacks and nightmares. Clinically, we've found that this has a lot to do with our fear extinction response. This is our ability to inhibit or suppress the fear response. This has to do with three main areas of the brain. We've got the amygdala, which is in charge of lots of emotional responses, including creating fear. It tends to be overactive in adults with PTSD, but otherwise shows no structural differences. We've got the ventral medial prefrontal cortex, which has the ability to inhibit the amygdala, and therefore the fear. It's been shown in adults with PTSD that this has a reduced grey matter volume, which also increases the severity of PTSD. There are some treatments which can reduce these symptoms over time, though. And last of all, we got the hippocampus, which can contextually limit the fear responses of both the ventral medial prefrontal cortex and the amygdala. Again, in adults with PTSD, it's been shown to have reduced grey matter volume, which increases the severity of the symptoms. There's a bit of a debate over whether this is required or a comorbid condition, but there are treatments available which can reverse the volume deficits. PTSD is a big problem for youth, affecting about 5%. It has a high comorbidity with other mental illnesses, such as depression, anxiety, and ADHD. And the study notes that adults with childhood trauma tend to have higher rates of depression, suicide, and substance abuse. My first critique is here. I would have liked if they used some information on youth or adolescents, such as from the National Survey of Adolescents, which showed much the same thing. The PTSD is a risk factor for depression, suicide, and substance abuse. Past research for PTSD in children, there's been an interesting disconnect because they haven't found the same as with the adults. So the amygdala didn't find any structural changes there, which was to be expected, but the ventral medial prefrontal cortex, there were no differences in total grey matter volume. And in fact, there was one study which showed that this area was actually bigger in youth with PTSD. For the hippocampus, a meta-analysis didn't find any hippocampus volume changes. There was one study that was hopeful, demonstrated that it did reduce over time, but there were no controls for this sample, and quite a small sample size, so we can't really rely on that one. So the question becomes, why is there a disconnect? One theory is that these are delayed developmental effects. So you get the PSD as a kid, and it affects your brain as you're growing up, and you don't really see the reduced volume until you're a bit older. This study posits that it might be because of poor imaging, though. They've been using older MRIs in the past. The ones we have now are much more detailed, so we could give it another go with a better scanner. And with that, hypothesis one is that youth with PTSD will have reduced ventral medial prefrontal cortex volume, and that age will negatively predict hippocampal volume. Hypothesis two is that re-experiencing symptoms in particular would inversely relate to grey matter volume in the ventral medial prefrontal cortex and hippocampus. With a small sample size of 55, I won't go through the complete list of exclusions and measures, but we'll point out the important bits. All the measures were psychometrically valid and reliable and used within appropriate norms. There was extensive but reasonable exclusion criteria used. They could have been a bit more clear about whether participants were excluded for psychotropic medications. It was listed as an exclusion criteria, but it was also noted that participants were not taken off of the psychotropic medications. They used a modified DSM criteria for PTSD. 82% met the standard criteria, and there is some support for using this modified criteria in past research, but it is worth noting. Also worth noting is that 7 out of 27 of the PTSD condition didn't actually do one of the scales for PTSD, which could be significant because it's quite a portion of the sample. The scanner they used was a T3 scanner, which is a magnet which is twice as powerful as past research in this area. It's well regarded for detailed scans. They use voxel-based morphology, BBM8 toolbox. One of the control participants had to be eliminated, though, from moving around too much in the scanner. Statistical test employed was a two-sample T test comparing PSD with the controls, and a multivariate regression was performed within the PTSD group only. These two tests are good for adequate tests for testing the hypothesis mentioned earlier. Results are as followed. This one is the ventral medial prefrontal cortex. You can see it's got higher volume in the controls than the PTSD group. Here we're looking at the hippocampus over time. We're noticing that the control, the volume increases over time, but in the PTSD group, it decreases over time. This is also how patients re-experience symptoms over time, the tendency to re-experience symptoms, which was associated with lower grey matter volume in the subgenial anterior cingulate cortex. Ultimately, both hypotheses were supported. They found reduced ventral medial prefrontal cortex volume, which is replicated from previous adult PTSD studies. They found it particularly in the medial frontopolar region and the anterior ventral medial prefrontal cortex, where the volume was inversely related to the illness duration, but not related to the severity of the symptoms, which suggests that these areas contribute more broadly to the persistence of the illness rather than the PTSD symptoms themselves. The results are at odds with some past research, which actually showed an increase in size in these areas for PTSD patients. It's the only past study to use similar imaging techniques, and they suggested that the reason might be because they were looking at slightly different areas of the ventral medial prefrontal cortex, and that 50% of the youth only 50% of the youth met the standard criteria for PTSD. So they suggest that maybe that their sample had less serious PTSD than the current sample, which has 82% meeting the standard DSM criteria. Also found the hippocampus. They found that there was decline in hippocampal volume that was associated with age. This suggests an ongoing toxic process in development, which may involve an interaction between childhood trauma exposure and genetic susceptibility in some way. This is very important in terms of developing treatments, because if this is true, then it means that it really is treatment, the sooner the better, because this effect will only get worse as time goes on. Volume as well was inversely correlated with re-experiencing of symptoms. So the decreased volume may cause PTSD symptoms over time. And these two facts together support hypothesis 1 ultimately. The second hypothesis was also supported, as the ventral medial prefrontal cortex and hippocampal volumes were inversely associated with the re-experiencing of symptoms. It was a particular area it was the sublingual anterior cingulate cortex, which implies that this is a specific area of the ventral medial prefrontal cortex relates to the PTSD symptoms. A post hoc analysis found that these two areas were not associated with any other symptom clusters, but suggests that they just cause some of the symptoms and not all. Limitations noted by the study was group differences, the fact that it was cross-sectional by nature. They had pretty small sample size overall. There was no trauma-exposed healthy comparison group, which would have been really good for sussing out whether these differences were because of trauma or from PTSD itself. And they noted the high depression comorbidity, but I feel like this is the biggest weakness of this study, as it was 63% of the experimental group were comorbid depressed. There's quite a lot of research which shows that depression can reduce the ventral medial prefrontal cortex and hippocampal grey matter volume, which was the primary finding of this study. Also to note, the past research, the one that was really similar to this one, but showed opposite findings of increases in those two areas, they only had a comorbid rate of 12.5%. So the findings in this study might actually be more indicative of the effects of depression on these two areas of the brain, not actually PTSD itself, which is a major limitation. The strengths included the imaging, which was very good. They found specific areas of the ventral medial prefrontal cortex. Some were a surprise and have not been researched as much before, and that wouldn't have been possible without this level of imaging. There's quite a few implications from this study for PTSD youth. That is that hippocampal volume is influenced by it, and that it's a neurotoxic process that can keep damaging the hippocampus over time, which really does point out the need for early intervention for this kind of thing. For the ventral medial prefrontal cortex, the results suggested that it's a pre-morbid or acquired trait that in turn will influence the illness's course and symptom expression. So targeting this area for treatment might be good for reducing symptoms, is the implication here. Also, this research set the ground for a lot of future research, because it did point out that some of the things we're seeing in adults we might actually see in youth as well. Longitudinal research would be much better, because then we could get some causation and links going instead of actually just correlation between two groups. Thank you for listening to my presentation.